Hey everyone, today we're going to dive into one of the most important specimens you'll ever handle as a pathology trainee, the pediatric rhabdomyosarcoma biopsy. We're going to break down the College of American Pathologists protocol and turn it into a clear, practical guide for you to use on these really critical cases.
It really all boils down to this one question. You get this tiny little core of tissue, and from that, you have to create the entire roadmap for a child's treatment. And with stakes that high, having a standardized, protocol-driven approach, well, it isn't just helpful, it's absolutely essential. So here's our game plan. First, we'll talk about why this protocol even matters. Then, we'll get into decoding the different histologic types you'll see under the scope. After that, we'll explore the huge molecular revolution that's changed everything, cover the key reporting details you just can't miss, and finally, we'll pull it all together into the synoptic report.
So, let's start with the big why. Why is this protocol so darn important? Well, you can think of it as the bedrock of your diagnosis. In pathology, consistency is everything, right? A standardized protocol makes sure that every single patient gets the same high-quality, comprehensive evaluation, no matter what hospital they're in.
Okay, first things first, let's be super precise here. This protocol is specifically for biopsy specimens from pediatric patients. So if you get a big resection specimen or if the tumor is from an adult, you've got to find a different protocol. This is probably the most critical decision you'll make the second that specimen hits your bench.
All right, let's talk about synoptic reporting. Don't think of it like writing a traditional paragraph. It's more like a checklist, a really important one. It's a strict requirement for CAP lab accreditation, and this whole data element response format means the oncologist can find every critical piece of info instantly without having to dig through a wall of text.
Okay, now for the fun part. Let's get down to the microscope. This is classic pathology, where you start to classify this tumor based on what the cells actually look like. It's morphology. So the first big split you have to make is between the two main players, embryonal and alveolar rhabdomyosarcoma. For embryonal, you're on the lookout for those classic tadpole cells and kind of patchy myogenin staining. Alveolar, on the other hand, it looks different. You'll see these round, almost lymphocyte-like cells, and the myogenin stain is going to be strong and diffuse in more than 80% of the nuclei.
Now, this quote, "This is a big deal." It signals a massive shift in our field. For decades, what we saw under the microscope was king. But now, as the CAP protocol itself says, it's the FOXO1 fusion status that really drives the outcome. And histology is no longer the primary tool for figuring out prognosis. This is the pivot point of our whole story.
And that leads us right into the molecular revolution. We're literally shifting our focus from what the cells look like to what their genes are actually doing, because that is where the real prognostic story is told today.
If there is one single gene you need to remember in rhabdomyosarcoma, it's FOXO1. When it gets fused with another gene, usually PAX3 or PAX7, it creates this powerful engine for tumor growth. Finding this rearrangement is one of the most critical prognostic markers we can possibly report.
And get this, it's not just about whether the fusion is there or not. The specific partner gene really matters. About 70% of the time, the fusion involves PAX3, and this is a critical detail. For patients with metastatic disease, that PAX3 FOXO1 fusion carries a much graver prognosis than the PAX7 fusion. This detail directly impacts patient care and family counseling.
So here's the absolute bottom line for every trainee listening. Molecular testing for that FOXO1 fusion, it is no longer optional. It is now the central required data point for deciding risk. Your report on that fusion status will directly determine which treatment protocol that child gets put on. It's that important.
Now, what about the less common spindle cell/sclerosing type? Well, it's not really one disease, but at least three distinct ones, and each is defined by its own unique genetic change. First, you've got the infantile type with VGLL2 fusions. Then there's the very aggressive MIOD1 mutated type you see in older kids. And finally, the rare intraosseous type with TFCP2 fusions. Knowing these different entities is just key.
All right, we've covered the big categories. Now let's dig into some other crucial details you need to be looking for and reporting on. Think of these as the finishing touches that complete that diagnostic picture.
First up is anaplasia, and the definition here is super specific. You're looking for these huge, dark, frankly ugly nuclei, at least 3 times the size of their neighbors, or you're looking for just bizarre, multipolar mitotic figures. These things should just jump out at you at low power. If you have to hunt around for them, it's probably not true anaplasia.
And you have to say how much you see.
Is it focal, with just a few scattered ugly cells, or is it diffused with whole clusters or sheets of them? This is so important because anaplasia is strongly linked to TP53 mutations, and finding it might trigger a workup for a germline condition like Leaf-Fermeni syndrome. So here's a quick rundown of those other key molecular markers we've talked about. A DICER1 mutation might point to a germline syndrome. A MyoD1 mutation, that tells you you're dealing with that really aggressive spindle cell subtype. These markers are just essential for correctly classifying the tumor and giving the full prognostic picture.
And now for the grand finale. We've gathered all our data, the histology, the anaplasia, the molecular genetics. Now it's time to put it all together in that synoptic report for the clinical team.
The rules are simple, but they are absolutely non-negotiable. 1. Use the data element response format. 2. Give each one its own separate line. 3. Keep that whole synoptic summary together in one spot in your report. And 4. Make sure you include every single core element the protocol requires. It's a checklist for clarity and for completeness.
And this is why we do it. This is the ultimate goal of all these rules. It's not about bureaucracy or just ticking boxes. It's about crystal clear communication. The whole point is to create a report that is so well organized that every member of that kid's care team can get the exact information they need in seconds.
So, I'll leave you with this final thought. The next time you get one of these small biopsies, just remember you're not just filling out a checklist. Every single data point you report, every molecular test you order, is going to directly guide the next crucial step in that child's journey. Your meticulous work matters more than you can possibly imagine. Thanks for tuning in.